So from the operating room team, and this is the community that we're here, this is among friends. You see us bring these cases in, some with ongoing CPR, some with hypotension, shock, any of those issues. And we had a case last week where we knew that we had a young lady with a retrograde, she had a type B dissection and she propagated backwards. And we know that the number one thing is to establish true lumen flow in any of those cases. And I want to dig into that case specifically, but from the operating room, when we mobilize, what are the questions that you as a team have for us that we can answer before we get into nitty-gritty of how to take a case? You hear us posting type A dissection, go. We're booking the case, and we book the case, and we tell you, we're coming in with this. Dolores, we'll start with you. What are the things that come to your mind?
Well, when you present a case to us, we hear dissection, and that's what we do to figure out is it a type A or a type B, or so that determines whether we're doing the surgery or vascular does the surgery. So we were waiting for you to kind of prompt us on that. But in the meantime, we're mobilizing.
Let's say it's a type A. Say we know it's a type A coming in, and you're kind of getting all the team together to get things taken care of. Type A dissection, we know we're going to be doing the chest. We don't really know the stability, instability of the patient, but we know they've kind of landed either in the ED or the ICU. They're on some blood pressure medications, and the way we've seen this team rally in a case of emergency is impressive. And you're to be commended for that. And so we want to know, what are you thinking? What's allowing you guys to do this? Because it's very successful and we appreciate it. So, we want to make clear, sometimes the ways of cannulation are important. Sometimes the anesthesia setup is important. And, that's what we're looking at when we're asking for this scan to be taped to the chest. And if we don't have that scan, we often can't tell you that information, or it's a surprise. So when, and I'll ask the panel this question, and you hear of a type A dissection coming in, and all of us have been through it and see it, what are the things that are going on kind of through your mind when you're getting the phone call? Say, Dr. Barnard, you're getting the phone call from one of the emergency rooms, and they tell you, I've got a dissection. What's your communication with the emergency room physician? What questions are you asking him to articulate, and kind of what's the game plan in your mind?
First of all, I don't get those phone calls. So I'm delighted to report, so I don't take calling. I'm also, have to admit, I'm suffering from PTSD because I saw the calculus equation that Dr. Lair showed, and it just brought back really bad memories from college. So, I think that this is something actually I was going to ask the panel. I'm going to turn the question around to the panel, and I think we need to discuss a little bit optimal management of once we get that call, what should we be telling the sending staff? Maybe Dr. Lair, I guess this is your lecture. And how can we do better than what we currently do? Because we have had cases that were crashing on the way in or crashed right, and over my career, I've probably had at least 5 or 6 patients die literally outside the door. Probably Pat has seen that happen once or twice too. And once that happens, you cannot get the patient back. So I think my answer to that, my input from that would be we need to make sure that we are as ready as possible, as soon as possible, as Dolores said, as soon as we hear the word dissection. Because at any minute, the explosion and the time bomb can go off, and then you can never get the patient back. It's not even like a cardiac arrest with a patient with coronary disease. Those patients you can get back, but this is bad plumbing, and it's major plumbing, and there's no way to get control of it once it happens. So I think this is something that, as a center, since we're obviously, the data that I showed this morning, we're becoming very much the referral center for the greater Seattle area. I think that we need to try to optimize. I think we do a great job at it, but obviously our goal is to have a perfect outcome in every patient that we touch, but knowing that we'll never get there because it's a biologic system. But so Eric, what things come through your mind, and what do you think we can do better from your experience and Sam's experience and Pat, everybody, that we have currently experienced?
Well, I think we have to keep in mind that these patients are at high risk of having further complications. So number one, I think we need to establish what their baseline status is. First, hemodynamics. Are they hypertensive or hypotensive? We should be a little bit reassured if they're hypertensive, because hypotension already means that they're probably have a pericardial tamponade, or they've ruptured somewhere, or they've had such an extensive dissection they've lost blood volume that's circulating, or they have coronary ischemia. So that's number one priority to establish. Number two, we have to guide the emergency physician because they want to get that patient out of the emergency department immediately, which is the right thing to do. But sometimes they just need a few moments to get things under control before they leave the door. And so number one, if they're hypertensive, we have to control the blood pressure and the heart rate, that impulse control that I talked about. We have to provide them, potentially just give them parameters of numbers and get them started on the right medication so that they don't get started on nitroglycerin. We've had patients come over, even if we tell the patients or the physicians what they should be on, sometimes we still have patients walk in the door on nitroglycerin because the people in the ambulance said, well, their heart rate was a little bit slow, so we just decided to change it. So number one, we have to be really clear on what that medical management is. Number two, I think we have to be aware of how the patient is presenting. What are the complications that we need to be aware of and that we can be thinking through ourselves in our own mind and with the team? So do they have a cold leg? Do they have belly pain? Just kind of go through that arterial tree from the aorta, thinking of all the branches, and just in our mind, go through what is occluded, where is their flow? And are they making urine? So all those things, I think it's really important to communicate with the emergency physician and make sure that we understand that patient as best as we can before they're on the truck and on their way here, so that we can be fully prepared. If they have a cold leg or bowel ischemia, going straight to the OR is probably not the right thing to do. It is a type A, but we can end up in a lot more trouble because of another few hours of bowel ischemia that if we do a great operation and get them off the table, they've now had an additional 6 to 12 hours of bowel ischemia, maybe longer before we realize it. So it might be better to divert and go to the hybrid room and call our vascular colleagues and do, stent the descending or the abdominal aorta, deal with malperfusion first. So all those things I think are important, and I think we go through this in our mind, but it might be appropriate to write these steps down, and so we're all going through those same kind of like a checklist.
So, can I go ahead?
Please.
So, Dr. Hayes, can you sort of chime in a little bit? Tell us, since you've been working here with us now for a while, when should we be calling that we're not calling? When have there been times that you wished we would have called sooner?
Well, that's never happened.
Glad to hear that.
Well, I think Eric touched on the points that really, if you have a patient who you think has a serious component of malperfusion, that you're going to be dealing with a type A dissection, but they have specifically the organs that we would worry about most would be the gut and prolonged ischemia for the gut. And also, a limb. Occasionally, there's an instance where obviously they've lost a kidney or they're malperfusing a kidney, but if it's one kidney, we'd probably push ahead with the type A dissection repair. But if they have significant evidence of malperfusion of the gut or a limb, then measures should be taken in those instances to consider whether we can do something to improve the perfusion, their malperfusion, prior to their type A dissection.
So that brings up another question in my mind. Having done this for a long time and seeing a lot, quite often that demon raises its bad head later on, and it's almost too late. So are there signals from the CT scan? Are there signals from any time while we're on the way to the OR and while we're operating that you guys can be alerted to the fact that you should be doing something right away, either following us immediately in the operating room or going to the hybrid OR in terms of a more timely intervention?
I'll let Kira chime in on this also, because I'm sure she's seen some cases in Chicago. But I think today, because we get a CTA of the whole aorta, that tells us a lot more than what we did in the past. When, when you and I were first in practice, we got angiograms. We don't do arteriograms anymore for dissections, and I think that the imaging is very important. So proper imaging, if you've got a patient with a type A dissection, we need to see the whole aorta, is what we need to see. So if we can see the whole aorta, then we can get an idea of what's going on in terms of anatomically what's going on. And then in addition to that, clearly what kind of state the patient's in. If they're in shock, are they in shock from blood loss? Are they in shock because they're septic, because they've got mesenteric ischemia? Do they have an ischemic limb on examination, obviously? So I think imaging is really critical for that. Maybe Kara can pipe in anything.
I think it's a combination of imaging, but also timing. Did the patient come from 2 hours away? Did they come from 30 minutes away? And, if you have imaging that shows, no flow through either iliac, I think you can make an argument, even depending on extent of the type A, are you doing an emergency X bifem while you guys are getting the chest open? That kind of thing.
Also is your clinical picture. If you have a lactate that's climbing, then you know you have malperfusion and tissue malperfusion. Often you have collateralization, and most of the time the thought and the evidence has shown that reestablishing true lumen flow antegrade from the aortic dissection will resolve the malperfusion. And there are certain cutoffs that are now coming into play, as example, a lactate greater than 4 or 5 and not improving with time and worsening. That's an indication that you may have a malperfusion that needs to be addressed first before going to the aorta. The acid-base status, mental status as a surrogate for kind of mental perfusion and things as well. So all those things I think come in absolutely as part of which algorithm that you do. But I think greater than 70% of the time, if there's a distal malperfusion like a limb, often we've done a cut down, we put a limb catheter down one leg on bypass to perfuse that limb, assuming that everything else is still going, continue with the antegrade flow, establish forward flow from the true lumen in whichever way we need to do. And if there's malperfusion, that's given rise to the antegrade TVAR, the antegrade graft, to establish as much forward platform as you can into the descending aorta that can be supplemented if necessary afterwards. So that's just the lab work might help with that too.
And again, just in a perfect world, something Eric just said keyed my thoughts on this. I think, as we go forward, maybe from this conference, we need to be very deliberate and intentional and write this stuff down and send it out to the EMT programs. Try to save those, those subsets of patients that say, here is our protocol. If you pick up this patient from, Edmonds, or you pick up this patient from OMC or whatever, here's what we'd like to have happen and be in communication with us. And here's the, the 328 aorta number so that we can be talking while the patient's in process, because bad things can happen between A and B. And so that would be something that we can think about doing.
Absolutely.
Yeah, and I think one of the things that I know I've done with Eric and Sam is the early phone call to the vascular surgeon helps, and that is, I'm taking a patient to the OR with a type A dissection. He's got an ischemic leg. He may need. We'll see what things look like. He may need a fem when we're done. And we brought, Sam and I brought a patient over in the middle of the night. He'd done the dissection. Of course, he finished at 2 or 3 in the morning, at which point in time I had to come in because we had static obstruction of the SMA. Remember that case?
Absolutely.
So we took that guy directly to the hybrid room, did an SMA stent on him, and he turned the corner and did fine.
And there was another cold leg that we were about to do.
There
The
was
same thing. Once we came off, we had a pulse when we were done. So we ended up not needing to do something.
Yeah.
So it goes both ways. But yes, the early, hey, there's something else coming in.
Yeah, and we had another cold leg that you came off a bypass. His leg was still ischemic, but not critically ischemic, and we actually let him stabilize for 24, 48 hours, and then we brought him over and did a fem on him then. So I think there are all sorts of scenarios, but I think involvement of both cardiac and vascular surgery in these cases now is going to give us better outcomes.
I'm going to ask our anesthesia colleagues, Juan and Wendy, anybody else here? Just the two of you. And see what you think about when we bring to you these cases into the OR, what's going through your mind? What are you thinking? Your induction, our request for bilateral radio A lines, the timing, the arrhythmia, the TEE. How are you orchestrating that initial landing of the patient? Because that's where we have the ability to get the most information and intervene as quickly as we need to. So what are you thinking as the patient rolls in?
All right. First of all, congratulations on a well-managed course.
Thank you.
I have enjoyed it. From the anesthesia and critical care perspective, I think the current classification of aortic dissection is beautiful because of its simplicity, but also I think it needs to be revised because you get this false sense of security when they call you for a type B. It's just a medical management, where I think we're moving away, trying to identify those potential interventions earlier. And then the type A's could be a simple type A or could be a very complex type 1, going all the way down. So from my perspective, number one is stability, hypertension management. If the patient comes in awake, my main goals are to avoid hypertension because I have experienced rupture and worsening dissection as the patients are being wheeled down to the operating room. So it's all about the presentation, intraoperative management, and maintenance of good communication with perfusion, because if you start to see escalating vasoplegia, escalating vasoactive support, then you start to worry about gut malperfusion while you're on bypass, and see how can we re-look and see if there is a malperfusion that needs to be have the vascular surgeon involved before going to the ICU and continue to have the worsening base deficit. So I pay a lot of attention into the metabolic component and how much bicarb is perfusion giving, as well as vasoactive support. If all of a sudden we're giving more norepinephrine than cyanokit or vitamin B12. And finally is the endotheliopathy that happens after big surgery and the coagulopathy to be on top of that as well. So measuring the fibrinogen, thromboelastography, and platelet count to be ready. So it's a coordinated effort. From the ICU perspective, I get to see these patients when they come and when they arrive, and then in the OR, I get to manage them intraoperatively. So good communication with you, understanding what type of operative approach you're going to do. Are you going to extend it down? Sometimes I've seen that you do the TVAR component as well. It's communication is key.
Absolutely. Introduce yourself, please, in the back.
Mike Brown, I'm an emergency physician out in one of the community hospitals, Ballard Hospital. First off, I'd like to request that people speak into the microphone because back here it's a little hard to hear sometimes.
Yes, sir.
But secondly, as an ER doc, I've sent several of these patients here, and the questions always come up. Do you want these people intubated before we send them down? And we talked to somebody at the OR. This involves things like consent. How do we consent these people? I realize time is of the essence, but is it preferable to have the patient come down intubated and going to the OR? And so some of those issues always come up with these kinds of cases.
I mean, I'll ask Juan to comment on this, but we know that the patient's vascular reserve is a complete sympathetic drive, is what's driving his blood pressure. When we intubate them and sedate them, we lose that vascular tone, and so they become hypotensive. If they're mentating and they are adequately protecting their airway, they should come in awake. If they are not adequately preparing their airway, then they have malperfusion to the brain. That's a concern for a stroke. Then we have to protect the airway in that regard, and it's most likely not going to be as good of an outcome. So if they are mentating and protecting, we would advise to not intubate, resuscitate, not intubate, and expedient transport. Juan, Wendy, agree?
Yeah.
I would agree entirely. I would definitely not intubate electively. I would prefer to manage these cases just like PEs and massive PEs as close to the operating room as feasible. Obviously, if your patient has lost consciousness and is comatose, that's another story. But if the patient is awake, that's golden, and I would just send them.
Part of the issue there is that we're often faced with having a multiple, not hour, but wait to get somebody down here. We also have traffic issues in certain times of the day. And so sending that patient in a rig that they may have to be intubated en route is always an emergency issue. And so secondly is we often have problems with not having the availability to send a patient here because nobody can accept them because there are no beds available. So that is a very difficult situation we face on a daily basis. So maybe you could comment on that as well.
Dr. Barnhart?
Yeah, I'd really like to comment on that. That should never happen here. Let me just say that again. That should never, ever happen here. And you can call me directly until January 5th, 2019, or you can call Dr. Pat Ryan after January 5th, 2019. For this diagnosis, the ED doc, once they call us, should never be faced with that. We will make a bed. We will make a bed. So that you probably have heard that from other institutions, but I hope that you never hear that from here, from us.
One caveat.
Yeah.
If we are in the OR doing a dissection already, then we will not have capacity. But otherwise, we can always take the patient to our ER, directly down to the operating room from there, and then we figure the bed out later.
Just as a matter of interest, that actually happened. I had a dissection case that I was going to send down here, and you guys had one on the only table available, and he died. I think he died or he got transferred out, and the bed was suddenly freed up, so the patient went. That's happened to me.
Right. But if it's during the day, if for some reason you hear the dissection's going on, still call, because one of the other, we can do 2 dissections during the day. We have OR staff to do that, or even our OR staff, who many are here, are incredibly involved and engaged and passionate about the work they do. And so even if it's in the early evening, we quite often can mobilize a crew. So we should always sort of be your first default.
Well, go ahead, Pat.
I have a question for the panel, and this is probably something that pertains to the team setup, is that I'd like to hear from the other surgeons that deal with the type 1s. How do you think about your aortic cannulation strategy in different situations? So the arterial cannulation, because the team is going to want to know how to set up to get it ready, and they may be crashing, so it may have to be quickly. And Roland, too, if you could chime in,
So germane to cannulation is brain protection. And so whenever I'm thinking about a case, the first thing that goes through my mind is what's available to cannulate and how am I going to protect the brain? And then, not secondarily, but also important, is how we're going to protect the rest of the body. I used to do a lot of axillary cannulation because that makes it pretty easy. Just put a clamp on the innominate artery, and then you have, and then you have very easy antegrade cerebral protection. But that does take some time to do, and more recently I found that we've had very good success with direct aortic cannulation. You can cut out that part of the aorta that you've cannulated, and then either cannulate the graft or have a graft of the sidearm and go back on. And then we can still give antegrade cerebral perfusion with a separate line, a coordinates line, and then direct cannulation into the great vessels, or we can do retrograde cerebral protection. And so that's what I've been moving towards, is just direct aortic cannulation for most cases. But it depends a little bit really on the specifics of the case and where the dissection is, exactly what's involved, where malperfusion is. But at least for me at this point, my preferred cannulation strategy is direct aortic, and then secondarily either femoral or axillary.
Dr. Hernandez?
Well, I think it has to do with the context of the scenario. If it's an emergency, situation, then you don't really have time, I think, but to go straight up the middle, so to speak. But where I came from and in training, the approach was typically addressing what Eric had to say, was going right axillary, so that you could sew on a graft and have a means to really perfuse the brain antegrade by putting a clamp on the innominate. So, you know, that may change as I take on more cases here and start to do dissections and stuff, but that is what I'm most comfortable with.
Yeah, I would concur. You'll learn a lot about the nature of the flap in the ascending aorta from the CT scan and then also from the epiaortic probe. And if you need to get in quickly, that's your quickest access. Some people say you have to make sure you're in the true lumen, and so use the ultrasound guidance with the needle guidance, and you can tell when you're in the true lumen and the TEE. Some people say there's going to be a fenestration downstream because the patient has a pulse in the groin, cannulate anywhere, and cool. And so there's two thoughts of that. We always try to get into the true lumen, which is most often on the medial aspect next to the pulmonary artery, and just taking one stitch that's secured and putting that right in the middle. Assuming you don't have any aortic insufficiency and you're not going to distend if you're on, you can be pretty free when you're there. Even if we've had aortic insufficiency, we've just put an LV vent and different schools of thought on cross-clamping. We came from a school that did not cross-clamp a dissected aorta. Other opinions I respect, but there's thought that that can change the dynamic flow downstream. So in cannulating arterial venous, it's what's most expedient. And if you don't have a flap down below, and you've seen that from the CT scan, you can get to that quickly, that's another option if one is not facile with the ultrasound guided in the middle as central.
Echoes from the past. I trained with Dr. Richard Lauer at MCV. He would always routinely cannulate, exactly what you're talking about, in the ascending, in the arch medially, and almost never did we have a problem. Sort of interesting. You know, you never consider doing that now. I mean, you just did it blindly, but it worked out almost always. The second thing I would say, since we're talking about cannulation issues and strategies, it warms my heart, and maybe I should say cools my heart, that we're talking again about retrograde cerebral perfusion, because all of my partners know that I'm a big advocate of retrograde cerebral perfusion. I always have been, and I'm glad to hear the studies are ongoing, showing an early favorable nod toward that.
They're showing non-inferiority on...
I'll take it.
Yes,
I'll take it.
They're showing that with cooling and protection of the brain up to 40 to 45 minutes,
Right.
it is equal in terms of neurocognitive. The antegrade perfusion had a higher embolic stroke rate because you're actively cannulating into either a dissected aorta. You don't even know the distal perfusion that you have, but you have the benefit of flush with the retrograde cerebral. That's the Emory study that's going on right now. I think it's going to be a landmark when it comes out next year, whenever they've rolled enough patients to.
And having routinely, not to get too deep into woods on this, but having routinely done that, seriously, I have actually, you can actually see the blood coming out of the great vessels, and it's dark, which means it's the oxygen extraction is occurring, and you can actually see occasional debris coming out out of the great vessels.
Yeah, and we'll keep that on, keeping retrograde cerebral perfusion on before opening the aorta, so no air goes upstream, and then well into after reperfusing the aorta, so that you have almost a competitive flow. So whatever is coming through is going to go downstream and not go up the brain. So the timing of it in terms of on and off pump, I think, has made a difference as well. This is a good discussion. We owe you a coffee break before we come back. We have about 20 minutes, so go ahead and take a break. We'll come back and we'll continue our descending thoracic discussion. Tivar first.